talk about various ways. So advanced directives, when they will come into effect, they will come into effect when the patient lacks capacity. So how do we determine the patient lack capacity? Well, this is another big bag of a lot of question mark, because which is interesting is that who is going to determine the capacity? It will be the attending physician. It will have to be also confirmed by another physician. Now, I'm seeing that in the family health law, it can be a PGY2, it can be a psychologist, or it can be a nurse practitioner. This is something very new. So I don't know how this is going to play. We don't have necessarily to have a psychiatrist coming and say patient lack capacity. That's not a requirement. And there's no legal standard criteria for evaluation. We don't have a set of, question or things to look into. What do we look when we evaluate capacity? There's no such a thing. And so if you look at the law, you will see that unfortunately this has been left, and of course we do our best to mention that, but we have to see that the capacity is evaluated according to the decision making that we have in front of you. It's not a total lack of capacity, but for the decision that is at stake at that particular time. Who will decide for the person? So we have all those agents, healthcare agent if you are talking about the proxy. If not, if you are not having a proxy, it will be the surrogate, and the surrogate by order of priority, you have the guardian, the spouse, domestic partner. This is something new in the law. You will see that with Mrs. Korzenik. So that the domestic partner is now added to there's a definition though of the domestic partner. It's not someone who would just live with you for a week or so. There's a bit more requirement to that. You have to demonstrate. Also a close friend. We had recently a case that the woman, the decision maker was presenting herself as wife, ex-wife. What do you do with those one? So if you are legally separated, you are a friend. That's all you are. And if you are not legally separated, you are at the same level as a spouse. So this is something that we encounter nowadays with those families with multiple wives. In this case, there was about 3 wives, a few divorces, and so on. What are the criteria that the one who is going to decide, the agent that's going to decide for the patient, what are they supposed to use as far as standard? Substituted judgment, best interest, clear and convincing, put that very low on, and there's only one case that we are going to use that criteria. Usually we'll use those 2 first. Substituted judgment, that's a very difficult thing. It's like you trying to think what the patient would have liked to be done in that case. So it's like putting yourself in the place of the patient. So obviously it's not easy unless you know that person very, very well, unless that person indicated something. It is not an easy criteria to use. Oftentimes, and most of the time, we'll go with the best interest of the patient. This is something that we apply every day in medicine. We do a balance between benefits and harms and burdens, and we present that. And the more burdens there is, well, the least likely we are going to go that direction. The most benefits, of course, this is something that become more acceptable. The clear and convincing, I mentioned that just because, as we said previously, this is the only time when you are under the proxy law and you have to withhold the artificial nutrition or hydration. You need to make sure that you have clear and convincing evidence, either in writing or either orally. So that is one of the exceptions. And we spend a lot of time, and Deborah can tell you that in the past the ethics committee spent a lot of time trying to find this clear and convincing evidence, which is not always obvious. So we are in, and certainly in family medicine, I think there is not an obligation, but there's certainly an incentive for you to discuss with your patient, especially the one with chronic illnesses, to discuss and to raise the issue at advanced directive. And so I think that we need to be prepared to do so, and it's not just the signature that need to be there, but what is underneath. So as conclusion here, just a reminder that 2 things here, what is in red. The law does not require care that is medically inappropriate. And we had a few cases here in the medical ICU again last week, and If it is something that doesn't make sense, that's not appropriate, that's not indicated for a patient to offer, we don't need to talk about withholding or withdrawing treatment and try to find out an agent to help us to do that. If it is not indicated, the case was the patient who was on 4 antibiotics was spiking despite all the antibiotics, despite all the means that was done, it becomes a moot point saying that do we need to stop that? Yes, it does not do what it should do. The same with hydration. So just a reminder of that. It's sometimes difficult, and we are on walking on eggs at times because it's not an obvious concept. Do not apply all those living wills. Advanced directives do not apply in acute, potentially reversible situation. We have sometimes patients who come, they have a pneumonia, they need to go to the MICU, be intubated, receive antibiotics. We know it's reversible. You know that it's temporarily. And so that's not a terminal illness. So therefore you have to be very cautious, because some family will say, hey, they will come with a living will and say, well, here it is written, it doesn't want to be on the vent ever. Well, you need to make sure that the clause in those advanced directives apply to the situation in front of you. Healthcare proxy, is it the best? I don't know. Think about it. If you would like to really have somebody representing you and not on the list of the surrogate, well, you better have one. If not, if you don't mind, you trust the list, go with it. And I think I will conclude on that saying that when we talk about family, about advanced directives, and we really try to find the best decision for the patients, we need to have the medical facts right. There's no ethics and law without having especially in our field, everything starts with medicine. We have to have the facts right, and then after that we start about talking to other things. If you are going to present facts to a decision maker for the patients, well, we have to tell them what's at stake in order for them to make the right decision. Good communication, I still believe it is the best thing. If we know how to communicate with families and present facts, I think it's the best way to avoid, first, lawsuit, second, to get to the best decision, because they will mix messages, confuse patients and family, especially in advanced illness, when it is so difficult already to make decision. So I'm stopping there. I hope I did not overdo it, because Deborah has many slides as well. We try to go into tandem and each our slide, not to have too many, and respect the time for the others. We'll take questions at the end. We did not want to interrupt because it's kind of a flow in what we are saying. So if you have burning question, we'll come back at the end.